So, there we go. What is this talk about? So essentially, I am the big data person at Partners who has been working on this problem for some time, which is how do we instrument our healthcare system to do science and innovation? And there's clearly an issue in that we need it. We need our healthcare system involved in science because here's an example where there was a gene variant for a gene that we knew was involved in diabetes, the PPAR gamma gene. And different clinical trials were done, which were all over the board. So here, this is what it would be if it was a average non-influential variant. And a clinical trial was done showing that it was protective, and then one showed that it was not protective. And it wasn't until down here that it was shown that the variant was actually protective, and it's now the basis of many of our anti-diabetic medications. And the difference was that the sample size had to get very large before it achieves that statistical significance. So we needed a way, right from the beginning, to at least utilize our data to find cohorts of patients that we could sign up for our clinical trials. The old ways of doing this was not working because in the old days we would go to the diabetic clinic, right? But when in the 90s the game changed and we got primary care providers, we no longer could go to a single clinic and we had to rely on the enterprise as a system. And what tied together our enterprise as a system was now just electronic medical data. And so finding patients using electronic medical data was very important. Now the problem with electronic healthcare data, as I'm going to show you, is it's actually difficult to work with for two reasons. Number one is risks of a data breach. So you can't just distribute it around and have people working on it when you've got confidentiality of patients at risk. And this is a very important thing that we have to be thinking about all the time when we're using this data. The second is the data is not collected for research. It's really collected for billing, number one, and physician communication, number two. And so neither of those are research. And so what you find is optimization of codes and so forth for billing, and a lot of unstructured text, right, notes, because doctors can communicate effectively that way. So we have a problem taking that data and using it for any kind of serious scientific endeavor. And that's another thing that we need to do with this for science. So we started by creating at Partners Healthcare this data repository called the Research Patient Data Registry, where we put together all this data from different facets of the healthcare system, including diagnoses and medications, physical findings, demographics, pathology data, and so forth. And by the time we got finished, we had 6.7 million patients and 2.6 billion facts on these patients into this very large database, which would be unusable by most of our researchers. And so what we did is we created this query tool that actually allowed us to do queries, but queries that like a doctor could do, right? Which means that they have to be pretty simple, number one. But number two is you have to be able to learn the system fast because the attention span of doctors are like really small. And they really just want to get in and out of the system so they can get on with their real work, which is like doing the clinical trial or doing their analysis. So we had to let them find cohorts of patients quickly. And then once they did so, and we had to make sure that it was in a de-identified, obfuscated way so we wouldn't be exposing all 6.7 million patients to the whole healthcare system. Then when they have individual studies, which if you have a study and you want to do something very specific, you apply to the Institutional Review Board. They look through your documentation. They say, okay, this is a worthy project. And the ability to get names of patients so you can recruit those patients is granted. And then you can actually use those names for a few people who can look at them in order to do the study. And so at that point, they can get back all kinds of data to help them with their studies. And that's the key part where then they're able to do some pretty deep science and overcome some of the limitations that's in the data. Because the first pass of data will give you codes and so forth, which, as you'll see in a minute, are not all that accurate. But with EHR data, you can actually validate the data using all the other big data that exists in the system. And that's the key to be able to be performing good science. So in the first step, we put all the patients in using their HIPAA notification, which we're allowed to do because we give patients notification that their data is going to be used for research. But we anonymize the data at that query tool, which I'll show you in a minute, so that they can't find individual patients through that tool. It only gives you back aggregate numbers. And we have this concept of an established medical investigator who can use the tool. So not any temp who walks in can use it. You have to be an established medical investigator or have a team or be a member of a team led by an established medical investigator. In step 2, when you've gotten your IRB approval, now you can get the actual data, identified data, if you want to do your little study. But only the established medical investigator can get that. And there's still restrictions on the kinds of data. For instance, screening genomic tests can't be given. So the query tool that we found doctors can use is one that looks like this, where you have the traits of your patients over here, so their diagnoses, lab tests, and so forth, various things that they've obtained from the workflow, the normal workflow of doctors as they're performing clinical care. And we're doing our coding, and we're getting lab tests, and writing our prescriptions, and so forth. So all of those get put over here so you can use those to designate what kind of patients you want. And over here, it's trying to be a Venn diagram. Each square is a circle. And if you put two things in one circle, or square as it may be, it's easier to program a square than a circle. If you put them in a square, then it will find you patients which have those attributes ORed together, logically ORed like a Venn diagram would do. So if you wanted to find patients with hypertension and diabetes, and you put them both into this first square, you'd find all the patients who had hypertension or diabetes. Probably not what you wanted, but that is what you're going to get. And you're going to say run query, and it's going to give you the number of patients that have diabetes or have hypertension. If you want to logically AND them together, you put hypertension in one square here, and then diabetes in the other square, and then you can that will logically AND them together to give you all the patients who have diabetes and also have hypertension. And you can do that with you can get as many panels as you want. You can use ages and demographics of all sorts, education, and anything that we collect in the course of clinical care to narrow down your cohort. And so it kind of looks like this, where you can use the hospital of service, you can use demographics, you can use your ages or races in the query, vital status, zip codes, because it's obfuscated, diagnoses. And diagnoses are organized in this hierarchy. So one of the problems with all medical data and exposing it to people who want to use it is that everything is collected in classifying people is done at different levels of granularity depending on the task. So sometimes you want to know very detailed, like what kind of myocardial infarction it was. Other times you just want to know what the circulatory system, if they had a circulatory system disorder or not, because you want to put them into a clinic. So the fact is that this is collected at various levels of detail. And it's a huge burden on doctors to say, well, even if you just want to know what clinic they are, you have to say exactly what the most detailed thing about them is. So because of that, you get lots of different use cases of data being collected. Remember, it's not being collected for research. And it'll be collected at different levels of detail and different granularities. So you have these hierarchical classification systems that you have to deal with. And so when you put them into your query tool, you're going to drag a folder over with the various granularities in them. So when you drag ischemic heart disease over, you're going to get all these different kinds of ischemic heart disease in one drag, rather than having to go into all this detail, but it could be available in that detail. So then we'll have, in the same kind of way, symptoms, codes of various for injuries. We'll have laboratory tests of different classifications, medications, genomics of various kinds. And if you have something with a value like vital status, you'll drag it over, and then you'll designate that in this case you wanted your heart rate to only be with patients who had a heart rate of greater than 100. So here, if you want to make a query to find all the patients with acute myocardial infarction, you'll drag over acute myocardial infarction from your system here, and you'll say run query, and indeed it will run for a few seconds, and you'll get 120,000 patients. Now this is where your problems are actually going to start, because you're going to think you have 120,000 patients with acute myocardial infarction. But the fact is that lots of patients get coded for acute myocardial infarction and that aren't having acute myocardial infarctions, at least not in that hospital. And you can see this when you go and you try to increase the specificity. For example, if someone has an acute MI, especially in the era that we were talking here, they had to get either a CKMB fraction that was greater than 3.5 or a positive troponin, right? But if you put that in and you run the query again, then you find much more realistically that you have about 21,000 patients. So what we find is that the codes that people use to classify their patients are often not correct. They get you close to a patient that might have that diagnosis, but because of the way that people are taught to code, in which we're said, you know, if they have any chance of having diabetes, call them diabetes, right? Or if you're trying to rule out diabetes, call them diabetes. Or if you want to get a glucose tolerance test, you have to put in that they have diabetes, which is obviously wrong since you're just trying to test if they have it. So that is where our problems actually start. And to solve those problems, you have to look through the data in a very detailed way, which if you get IRB approval, you can actually get an identified data set of patients, and you can read one by one what their reports actually show them to actually have. So you can actually get the reports back, you can get back their notes and find out what they have. Now but you have to be in the study. So that means that the only people that would actually understand the detail of what patients have would be those few people that actually got back the results that were in that IRB approved group. So what we did to solve this problem is we developed a new system called I2B2, or Informatics for Integrating Biology to the Bedside. And what does it do? So it's software for explicitly organizing and transforming person-oriented clinical data such that we can get the truth not only based on the clinical data, but also trials and genotypic data in a database. And we can come up with various algorithms that other people have developed in order to identify what people actually have through what we call computable phenotypes or computable data. Algorithms that use all the data to figure out what the diagnosis is, because the clues are in the medical record in terms of what the patient actually has. Just a code for diabetes, look for, doesn't matter, but maybe if you look for a hemoglobin A1C greater than 6.5, or you look for if they're on an anti-diabetic medication, now you have a computable phenotype that you can use to much more accurately assess what a patient actually might have. And so we made this a portable and extensible application framework so that these new rules and new types of analyses can be incorporated by people other than us, because we're not actually, we're good at some things, but there's so much more out there that we're not good at, that we knew right from the beginning that we wanted to make it something that other people could add to and not be based on what we're doing. And so we have a user community that actually is able to add to these software modules called an I2B2 cell, something that can be assembled into different analytic modules, some that control what you classify things as, some that do natural language processing, that can then pull information out of databases and present it to the user. And we even make it so that you can put all kinds of big data, including genomics, text, unstructured notes, and so forth, where the specialized teams will pull that data out and use that data, but end up putting it in a way so that the clinical data warehouse can use the big data and put it together for the users of the system. We use a big index called the STAR schema. Even that's not based on our work. It was actually invented by Kimball. Ralph Kimball, and it ends up looking like this workbench. And so what this workbench is, it has these kinds of query tools where you can use the attributes of the patients and use them to make queries. But then it also can show you the de-identified data in a timeline. So for example, if you wanted to find all the patients who were using prednisone or steroids with their asthma, instead of looking for just asthma and steroids, we look at patients who have albuterol use. And then with their albuterol use, are they getting their steroids? Because we're looking to see if their asthma is actually responsive to steroids. It turns out that some asthma isn't responsive to steroids. It tends to be in older folks, and we think that a different gene variant was responsible for that kind of asthma. And here, if we want to distinguish, separate our patients into patients who are responsive to steroids or not in a high volume way, we can go through this and look at their medical history in an instant to see, okay, this patient's getting steroids with their albuterol. This patient did get steroids, but not with their albuterol. Maybe they had poison ivy or something over here. And so this person we're deducing is not responsive to steroids. And this one might be, but we don't have that much data and so forth. So by looking carefully at the data, you can start to extract much higher quality data out of what you have to begin with. And you can do this in things called like this timeline, where we're actually looking to see calcium levels after their event here. So we can find out what happened, right, after an event and how their calcium's changed. And we can look at drug effectiveness. But when you want to look at drug effectiveness, you have to be very careful. So we use visualizations quite a bit in order to really bring out the meaning in the data. So here, for example, we have a hemoglobin A1C test, and we take the average before and after the medication was started. And it looks like, so the green is before and the blue is after. And it looks like the hemoglobin A1C is getting much better, right, after the drug was introduced, except for these SGLT2s, which don't seem to be doing so well. Now, what might be the problem with this? So one of the problems with looking at any of this medical data is that it's not happening in isolation, right? So there's something that led a doctor to starting the medication. And just regression to the mean is going to say that if you start a medication when a person is high, because their glucose by their A1C seems to be out of control, their next A1C is probably going to be very low, right? Just if you go with regression to the mean. And so if you look only for a couple of months before and a couple of months after, you're possibly going to see something like that. And indeed, if you spread out your visualization to not just look at the first 3 months and the 3 months after you gave the medication, but actually you look at it for 4 years before and 4 years after, now you can see that little effect, you see, where the doctor made a decision to start people on their anti-diabetic medication. And you can see what eventually happened, which is not that much change to the hemoglobin A1C. And not only that, but your SGLT2s, once you look at it that way, you see, oh, the reason that you got that terrible thing was these error bars, and maybe they're even a really good medication, because when you start looking at it afterwards, you just don't have enough data, basically, with that one. So you have to use visualizations to look very carefully at your data and kind of set up and try to overcome some of these biases that you have in the data. And so we do this by various kinds of approaches. So the community of I2B2 users is coming up with these clever new approaches. Here's one where they tried, they were very interested in looking at Celexa, which was causing QTc prolongation. So when the heart beats, the electricity of the heart has to spread through it. And some drugs will cause that electricity not to spread as quickly as it should. And if you already have a heart defect, that will cause an arrhythmia, or the heart to not contract properly. Celexa is a drug that we use for depression. And patients that already had a problem with their heart and its electricity were being affected by this drug because it was affecting the spread of their electricity. But Lexapro, so the FDA gave a warning for that, And Lexapro, which is chemically exactly the same, except it's actually more potent than Celexa, it's the chemical enantiomer, did not get the warning. And so psychiatrists were switching everybody from Celexa to Lexapro because they didn't remember their organic chemistry. And therefore, and the suspicion was that Lexapro actually had QTc prolongation as well because it's the same chemical. But because the FDA would take another 2 or 3 years just to do the study, we decided to do it quickly. So we looked up a bunch of patients who had gotten Lexapro and lots of other drugs with, and what their QTc prolongation was before and after their Lexapro. And you can see it was from doing this experiment in silico, so to speak, we found that they had a short QTc prolongation that was even longer, actually, than the Celexa. So that, and here you can see some dose-response curves. So some patients had actually gotten different doses of Celexa and Lexapro with different EKGs just being done in the normal course of clinical care, and you can see that the QTc prolongation very dramatically. And here's the control, which is methadone. We also find that if we're looking for specific kinds of diseases, we can't always go by the codes when we do these kinds of comparisons where we look to see how many patients got a code of depression, and then when we looked at their notes, they actually were depressed at that encounter. And it turned out that most patients, if they got one code of depression, they would always get a code of depression, right, for every encounter. And yet we were trying to see if people were getting better on their medications, but their codes were always saying they were depressed. And so looking at the encounter codes, you could only see that they had a random guess in terms of whether they were getting better or not on their medication from these ROC curves. But if you actually did a calculation using natural language processing to look at the notes, you could get actually some very legitimate data out of these records. So when we looked at treatment-resistant depression, before we did this kind of correction, and we didn't do our algorithms, we would find no results. And when we do something like this, where we're looking for their images, and we would find that they had, we were looking for white matter tracks, and whether their fornix was thickened with and without treatment-resistant depression, we'd find nothing before, but after we would hone in on using all the data in the medical record to see if they were actually treatment-resistant or not, we could get this, linear relationship with treatment-resistant depression and less sprouting of their white matter from their imaging results. So in a general way, what you can do is you can use this kind of approach where you survey a subset of records that have a certain diagnosis, you pull features, all kinds of different features out of the electronic medical record, not just codes, but what medications they're on and so forth. You fit it with a regression algorithm, and you can greatly increase the accuracy of their medical data from something that's not very useful to something that's extremely useful just by working the data in the medical record using some of these algorithms. And that becomes extremely important when you have, when you're looking for different variants, genomic variants, and you can actually use these in queries now where you can just use the special rheumatoid arthritis classification that was calculated that's known to have a positive predictive value greater than 90. So we even know what the error bars are on it as opposed to the codes. And that allows us to build these complex study designs where we can actually simulate clinical trials in the medical record, where there's no such thing as being enrolled in a clinical trial in the medical record, but we can actually calculate based on their visit patterns whether we think they're around or not, and that helps us make predictions in terms of whether we would see a cardiovascular event if it actually occurred as a result of something like rosiglitazone. And we can make these very careful types of timelines where we can see here, for example, that here's a patient who really did have a myocardial infarction that was being watched. Some patients will have myocardial infarctions, but they're not being watched, or we don't know if they had a myocardial infarction, and so we can't calculate their clinical trial in silico. And we can confirm, in this case, that natural language processing proved that they really were on the drug, with these blue dots representing when the note said they were being noted in the medical record for being on the drug that they supposedly were taking. Okay, so all this calculating, right, leads to much better research. What we've been working on recently is how to use it in clinical care, and we use it through something called the SMART app, where we take the calculations that are being done in the electronic medical record in this big data scenario, and we start to apply them to certain visualizations that people can actually see in clinical care. So we began by looking at just finding better patients in clinical trials, where we do these automatic calculations where we could actually find patients who really had the diseases that we were looking for in the clinical trials. But later on, what we would find is that these out-of-the-box SMART apps could be used in many different ways to be insert these visualizations into clinical care such that we could actually show in a way that physicians could really consume very quickly some of these very elaborate calculations. For example, we could give a cardiac risk score, we could show them vital status, these vital signs and so forth. And we could do something that with big data for everyday clinicians, which was find patients that are similar. Finding similar patients is a common thing that people who practice clinical medicine are doing all the time in their heads. So when we see a patient and we're trying to predict their course of how their disease is going to go, it's very helpful for us to rely on other patients that we've seen in order to understand if this patient is going to be somewhat similar to that patient, have the same, about the same age, have the same diseases and so forth, and we'll be able to predict whether they're going to get sicker or not based upon what we know about other patients that we've seen. Helps in predicting successful therapies, determining expensive next steps, and avoiding complex diagnostic pathways that we don't need. And that's the opportunity that we have by combining this EHR data, the big data queries, and the SMART apps. And here's a common one for you, for example. So this is a growth chart. So we all have probably had our growth measured at some point by our pediatrician. And you can see that what is really happening is, in a normal looking chart, you'll have your growth compared to all kinds of other kids who have been through the system. But by having a SMART app, which compares it to lots of other data, you can actually derive new kinds of things in terms of compare it and see where on the regression curve they actually are. And you can figure their parents into it. So if you know the stature of their parents, you can actually adjust the child's expected growth by what their parents are, and thereby kind of bring this whole growth chart to a new level, right? To a new level of understanding, but using the same principle, just in a big data way, of comparing it to similar patients, but now who had similar parents. We also use this to solve a problem with MRIs. So one of the problems that we've had is we don't know what a child's MRI looks like. So if they had an event at birth, and we think that they might have an encephalopathy, and we get an MRI on them, it's not clear to us if that MRI is normal or abnormal, because a child's MRI actually changes as the kid gets older, because an MRI is basically a picture of fat, and you grow the coverings of your axons little by little as you get older. And that will greatly change the appearance of your MRI scan. So by taking children, normal children, and averaging their MRI scans, right, throughout 6 years, we could come up with what a normal child's MRI scan looked like. And that way, if we got an abnormal child who we thought might have encephalopathy and might have an abnormal MRI, we could compare it to the normal child through this big data approach to see if they actually had an abnormal MRI and needed to be managed, or at least we could prognose what might happen. And this can be displayed to the clinicians in lots of different ways. And then finally, we can do things like predict whether a patient is taking or is not taking their medication. So we follow different patients, and we digest it into, for this patient, a single checkbox or a red triangle for whether we think they're taking the medication or not. But actually, there's some pretty complex algorithms behind it, which looks to see how their prescription refills are going, right? And this patient, who's not getting perfect prescription refills, but is doing pretty well, is within the margin that we know it has been the same as other patients who have been compliant on their medication. But the refilling of this medication is out of that region. And so therefore, by comparing it to lots of other patients and having known what their medication adherence was, we can predict whether we think this patient that's in front of you is or is not taking their medication. So using these various techniques that we developed for scientific research to make the truth out of our big data records, we've now been able to extend that to clinical care and be able to do better taking care of our patients by using these algorithms, these big data algorithms, to extract the truth out of our medical records. And most of this is done by a team much better than I ever dreamed, and their names are before you. So thank you.